Dr. Balaga here. I have another terrific God Knowledge Doc podcast for physicians and advanced practice providers, including physician assistants and nurse practitioners. You should find this podcast very useful in your practice. This podcast is an update on LDL lowering. This podcast has been broadcasted in August of 2022. This is a montage of the cover of many of the books I've either authored or edited, and many of the slides and figures are from these books. This left figure shows how with age LDL levels increase. It's like my gray hair, it's a sign of aging. In neonates, it's between 20 and 30 milligrams per deciliter. And by the age of 10, it's around 70 to 80 milligrams per deciliter. If you look at the right table, you will see that in between 20 and 30 years of age, the LDL in men is around 121, and in women it's about 113. And by the time you reach between 60 and 75, it's around 148 in men and 161 in women. Clearly, you will see post-menopause in women, the LDL spikes when you compare it with men. This figure is from Jack and is from a book which Dr. Chris Cannon from Harvard and myself co-edited for Oxford University Press. This figure shows a log linear relationship between LDL cholesterol and the relative risk for coronary artery disease. This data suggests that for every 30 milligram deciliter change in LDL cholesterol, the relative risk for coronary artery disease is changed in proportion by about 30%. The relative risk is set at 1 for an LDL cholesterol at 40. The flip side is true. For every 1 millimole per liter or 38.7 milligrams per deciliter reduction in LDL cholesterol is associated with a 23% relative risk reduction in major atherosclerosis coronary vascular disease events and a 10% relative risk reduction in all-cause mortality. So double-digit reduction for every nearly 40 milligrams per deciliter reduction in LDL cholesterol. This figure is originally from the American Journal of Cardiology, but is now from the statin prescribing guide, which I authored for Oxford University Press. This figure shows that the biggest bang for your buck one gets with statin therapies with the first dose of 10 milligrams. With pravastatin, it's around 20%. With simvastatin, it's 28%. With atorvastatin, it's 37%. And with rosuvastatin, with 10 milligrams, it's as high as 46%. And for every 10 milligram increase in the dose, there is only a 7% decrement in LDL. It's called the rule of 7. For every 10 milligram increase, there's a 7% decrease. If you look at the table below, when adding non-statin therapy to statins compared with statin monotherapy, with ezetimibe, there is a 20 to 25% reduction. With bempedoic acid, there's 45 to 55%. With evolocumab and alirocumab, it's 50 to 60%. And with inclisiran, it's 50%. The three trials, the Improve It, the Fourier, and Odyssey outcomes trial, have all shown outcomes. With ezetimibe, it's a single-digit relative risk reduction. It is modest, but it was a proof of concept that statin therapy could be combined with non-statin therapy in patients with acute coronary syndromes. In the Fourier study, there was a 15% reduction in primary composite endpoint of cardiovascular death, myocardial infarction, stroke, hospitalizations due to unstable angina, or coronary vascularization, and a 25% reduction in the most serious secondary endpoint, cardiovascular death, heart attack, or stroke after the first year with evolocumab. The Odyssey study showed that targeting an LDL of 25 to 50 with elricumab reduced the number of atherosclerotic coronary vascular disease events by 15%, which is also double digit in patients with recent acute coronary syndromes. Keeping this in mind, the European Society of Cardiology and the European Atherosclerosis Society targeted an LDL of less than 55 for very high-risk patients, and this includes people from the South Asian continent. The 2018 American Heart Association American College of Cardiology guideline recommended adding non-statin agents in very high-risk patients with an LDL cholesterol of greater than 70 milligrams per deciliter. The National Lipid Association had a scientific statement, and in this expert analysis of the statement, if you look at the sixth panel here below, in South Asians, this statement recommended that an LDL cholesterol of less than 70 should be targeted in high-risk patients, less than 50 in very high-risk patients, and less than 30 in extreme risk patients from people from the Indian subcontinent. So lower LDL is better, and that is where we are moving forward with, because it improves risk. As you'll see from the left panel, extreme risk where we target an LDL of less than 30 includes vascular paths, for example, peripheral arterial disease, coronary artery disease, and a stroke in the same patient. And I'll let you all read these two tables at your leisure. In the European Union, the Da Vinci study described that the majority of the European patients with atherosclerosis coronary vascular disease were on either moderate intensity statin or high intensity statin. Only 9% were on statin plus ezetimibe, and only 1% were on combination therapy that included a PCSK9 inhibitor. In very high-risk patients, the ESC recommended LDL goal was achieved in 22% of the patients with high-intensity statin monotherapy, 21% of patients on statin and ezetimibe, and 58% of the patients on combination therapy, including a PCSK9 inhibitor. In a European retrospective study of over 14,000 patients, approximately 80% of the patients had an LDL cholesterol greater than 70 milligrams per deciliter on moderate to high-intensity statin. Despite inadequate LDL cholesterol goal achievement, most patients did not have a change or a titration in their regimen. And finally, in the US, comparable data from the Gould registry indicated that lipid-lowering therapy was intensified in only 14% of the patients with atherosclerosis coronary vascular disease and LDL cholesterol greater than 70 milligrams per deciliter. Statin was intensified in 6.3%, ezetimibe was added in 4%, and PCSK9 inhibitor was added in 2%. So these are several missed opportunities in secondary prevention. So in summary, in extreme risk patients, the LDL cholesterol goal is less than 30 milligrams per deciliter. In very high risk, less than 50 milligrams per deciliter, and less than 70 in high risk patients. Realistically, a lipid clinic managed by a pharmacist or an internist or a cardiologist with an interest in preventative cardiology is the way forward to achieve these targets. The future is probably going to be of shots. The inclisiran data, where they give 2 doses initially, followed by twice a year doses of subcutaneous injection, suggests that it is a very powerful LDL reducing agent, as much as 50%. However, we need more outcomes data before we prescribe it. However, it's been approved by the FDA, but the future is going to be shots, your flu shot, your COVID shot, and your lipid LDL lowering shots. And taking all these shots will prevent death due to death in patients with cardiovascular disease. Thank you.